The last major feature of the Bismarckian system in containing costs is through price controls. They do that just to curb the oligopoly power of hospitals and physician markets, like we've talked about. So the prices are negotiated between providers and purchasers, essentially those insurance companies. And it allows the purchases of healthcare, the sickness funds, to band together to exercise monopsony power. So monopoly is when you have a single producer. Monopsony is when you have a single buyer. And so it can counterbalance that oligopoly power of providers to lower prices. But it can also act to distort medical decision making. It's really difficult to set prices correctly because there's so many different kinds of healthcare services that a person might need, and it can vary based on their own history and their comorbidities as well. So the price schedules have to judge the relative value of, for example, seeing a patient for a regular checkup versus performing a heart bypass surgery. Is it 1,000 to 1? Is it 1 million to 1? People have to come up with these numbers in order to have price controls. Both private and public providers end up having to charge those negotiated rates, no more and no less. So this gives policymakers a lot of power to influence the behavior of healthcare providers. This negotiation process, while it's through these nonprofit sickness funds, it's just like heavily part of the purview of government. And governments use manipulation of these fee schedules to serve as a primary mechanism for regulating things like the supply of services, use of care, and the level of aggregate healthcare spending. So if you set the prices improperly, it can result in clinical distortions. It's nearly impossible to set it exactly equal to the cost of producing one more, which technically should be the price of it, because they just don't have all of the information, but also they have all these political pressures and limited budgets to pay the full price of production. So some prices are not going to end up matching the actual marginal costs and marginal benefits of care. And that's when you introduce distortions in the way that doctors treat patients. So you can set prices too high, like in Japan, where they set pharmaceutical prices a lot higher than even what is charged by drug companies. And so physicians in Japan tend to write prescriptions for high-priced drugs. Why not? They're so well reimbursed. And it ends up constituting nearly 30% of all healthcare spending, but only 11% that year in the United States. At the same time, you can also end up setting prices too low. So, for example, when cochlear ear implants were first developed in the US, Medicare and Medicaid priced them at really low levels. And so a doctor performing a cochlear implant would have to buy this expensive part, the implant itself, perform the difficult surgery, but only be reimbursed at a rate less than the cost of the device itself. Only a limited number of deaf people had the cochlear implant in the United States, but the device proliferated in Japan, where the reimbursement rates were set a lot higher. Another thing that they can do is to limit access to specialists. This is something that we've talked about in Beveridge models, but Bismarck countries can have similar kinds of reforms. So both in France and Germany, they have imposed gatekeeping in their Bismarckian models. Unlike in the UK, they are voluntary for patients. You can avoid the gatekeeper and go straight to the specialist and pay a small fine. So it's called soft gatekeeping, or you can see the GP and be referred on at no cost. Another thing they can use is health technology assessments, similarly, again, to the Beveridge model. They won't necessarily have formalized health technology assessment agencies the way that they would in a Beveridge model, but they can use those assessments conducted elsewhere, the cost effectiveness assessments done in other countries, as an input into their price negotiations. and into the decision of whether the insurance company or society is going to cover that technology. And again, it is proven controversial in these Bismarck systems, and not every country has adopted even marginal use of it. So in conclusion, in comparing the Beveridge and Bismarckian systems, the Beveridge system emphasizes equity and equality in access, while the Bismarck system relatively emphasizes patient choice and provider competition. Countries in the Bismarckian healthcare systems tend to have higher healthcare expenditures, but also tend to be a little bit healthier than the Beveridge systems by some of these common measures. So they are investing more in the care in Bismarckian systems. But no country perfectly embodies any model. Every country has some elements of both. Some of the recent reforms in the Beveridge countries are focusing on introducing more choice and more competition. And recent reforms in the Bismarckian countries, on the other hand, are bringing about things like gatekeeping and managed care that restrict patient choice, more similar to the Beveridge, like nationalized systems. So the Beveridge and Bismarck models themselves seem to be kind of moving towards one another and could eventually be difficult to distinguish. So that's it for the semester. Looking forward to reading everybody's papers, and I hope everybody's been staying safe.